Hi, and welcome to the High Risk Newborn PowerPoint lecture by Jennifer Faruzesh. Let's start with a few definitions of what we qualify as high risk. First, there's a preterm infant who's less than 38 weeks. The term infant is between 38 and 41 weeks, so these are not your high risk babies. Postterm is greater than 42 weeks. In the last few years, we have a new category of babies who are called late preterm infants, LPI, and these are babies who are born between 34 and 36 and 7 weeks pregnant. So it's a subcategory of the preterm infants. We used to treat these late preterm infants like term, but we have actually gathered data to realize that these infants have an increased in mortality and morbidity, and so we are treating them more like preterm infants and watching them more carefully, especially as it relates to temperature regulation, blood sugar regulation, and the ability to eat. Your small for gestational age infants are those who fall within the 10th percentile, and your large for gestational age infants are those who fall within the 90th percentile. All right, so let's look at intrauterine growth retardation. There are two different types of intrauterine growth retardation. One is symmetrical and the other one's asymmetrical. So when you're talking about symmetrical, you're looking at the weight, length, and head circumference, and all of those are smaller than expected. Also, the organs are smaller, including the brain. Usually, symmetrical intrauterine growth retardation occurs in the second trimester and is due to some fetal cause. The other type of IUGR is asymmetric, and if you had to choose one, this is the one that you would want to have. In this case, the head circumference is larger than the birth weight or the length. The length tends to be a little bit more normal, and the main thing that's really low is the weight. So you want that head circumference to be normal. You want it to have a normal sized brain inside of it. So in this case, the brain has grown properly, and it's just the weight and length that are reduced. The organs in general, the heart, those have all developed properly, and what they're lacking is subcutaneous fat. This is usually due to some maternal factor, and it starts later in the pregnancy and the third trimester. Okay, so let's look at some of the causes. So some of the fetal causes that cause symmetrical IUGR are congenital infections, discordant twins, where there is a sharing of blood between the twins and one twin ends up getting more nutrients and oxygen, chromosomal syndromes, and inborn errors of metabolism. The maternal factors that cause asymmetrical IUGR may relate to some underlying chronic disease that the mother has, some type of cardiac or diabetes or hypertension. They might be abusing some substance like cocaine or severe alcohol intake. They may develop uh, hypertension during the pregnancy and have poor nutrition that really manifests with poor weight gain in the infant. It's also women who are very young or older also have more problems with IUGR. A primip is more likely to have IUGR problems, and women who are gram multips, meaning that they have, I believe the technical definition is 7 or more pregnancies. And obviously, women who have twins and triplets, all those babies are going to be littler. Women who come from lower socioeconomic backgrounds because of the inability to get proper prenatal care and eat the right types of food. And of course, if there's some underlying placental problem, especially if the placenta gets old and gets infarcts and is not able to perform properly. Okay, let's take a look at another type of high-risk infant, and this is the post-term infant. These are babies who are born after 42 weeks gestation. Um, they can be average for gestational age or more likely LGA, which is over 4,000 grams. And what we really worry about with these large babies is birth injuries. There's also, because the babies, they're big, that you have more CPD and you have an increased C-section rate. And because there's a high risk of these babies um, being undiagnosed, the mothers being undiagnosed for gestational diabetes, we worry about hypoglycemia in the baby. So whenever you have a large baby born, one of the things you want to make sure that you didn't miss some type of gestational diabetes. So that's why any baby over 4,000 grams gets a blood sugar check. Okay, sometimes post-term infants are small for gestational age and have intrauterine growth retardation. This is about 20% of the post-term infants. So what happens is that the placenta gradually quits working properly. There may be infarcted areas, dead tissue within the placenta, and the baby's not getting the nutrients and oxygen that it needs. So these babies actually start losing weight in utero. There's something called post-maturity syndrome. It um, is for infants obviously above 42 weeks, and they demonstrate signs and symptoms of hypoxia and malnutrition, and they have an increased morbidity and mortality rate 2 to 3 times that of a normal term baby. Um, so other things that we're concerned about in the post-mature newborn is cold stress, so we're going to monitor the temperature. We're worried about hypoglycemia because the baby hasn't been receiving adequate nutrition and nutrients and glucose, and they've been using up their glycogen stores. Um, for many different reasons, cord compression, having period of hypoxia, they are at risk for meconium aspiration. So we're going to be checking the fluid when the woman ruptures and being prepared to suction after the baby is delivered. If the baby's been for periods without enough oxygen, then they've probably been compensating by producing more red blood cells, which will result in polycythemia. And then as those red blood cells break down after birth, that's going to put the patient at risk for jaundice. Because of lack of oxygen, because of hyperbilirubinemia, they're at risk for seizures. Okay, so when you look at the post-mature infant, lots of people will refer to them as like a little old man. Um, they're very hyper alert, hyper vigilant, wide-eyed, have a worried look on their face. Their skin is like hanging on their body because they've lost so much subcutaneous fat. The lanugo and vernix that goes away at the end of the pregnancy is all been absorbed and lost, and their skin has been exposed to the amniotic fluid, and so therefore the skin is dry and cracked and peeling. When you do a gestational age assessment on them, you find that they have a lot of the physical signs and the neurologic signs of maturity, but they're little. Okay, so um, they have intrauterine growth retardation. Um, they are very good eaters. They act very hungry. So what are we worried about? We're going to be checking their blood sugar. We're going to feed them early and frequently. We're going to check their temperature. We're going to monitor them their neurologic system, their respiratory system. We're going to check their labs. Okay, let's go on to LGA. These are infants at the 90th percentile. It could be that genetically the woman is just prone to having large babies. Also, they're more common in women who've had children before, also more common in male infants, babies with erythroblastosis fetalis, and also mothers with diabetes and gestational diabetes. So when you look at these babies and you're going to see that, oh, the mom's measuring larger than gestational age. And so then you're going to go in and look at the baby and get an idea how much the baby weighs, and you're going to look at the head circumference and the length. In women who have diabetes, usually the head circumference is normal and the length is normal, but the weight is very much increased. So these babies look chubby because their length is normal. It's not higher than normal, right? Whereas someone who's genetically prone to it, usually the body is well proportioned. The length is big as well as the weight. So the baby might be, let's say, 53 centimeters and weigh 9 pounds 2 ounces. All right. Whereas a gestational diabetic mom, the baby will be 50 centimeters long and weigh 9 pounds 3 ounces. Okay, so why do we worry about babies who are large for gestational age? Why do doctors induce when they think the baby is going to be too big? Basically, it's because they're worried that the baby's not gonna be able to fit through the pelvis, that you're gonna have some cephalopelvic disproportion. And because of that, the baby could suffer trauma. Okay, and um, the, when you have big babies, they're more likely to be breech presentation. When they're delivered, they're more likely to get stuck in the pelvis and to have shoulder dystocia because of the extended second stage of labor. They're more likely to have asphyxia, fractured clavicles, brachial palsies, phrenic nerve damage, to have skull fractures and cephalahematomas. And because they have the CPD, they're likely to have increased rate of having a C-section. So we're looking at caring for the infant of a mother with diabetes. And although they are large in size, frequently they have similar problems associated with a preterm infant. Babies of gestational diabetic mothers frequently end up in the NICU because of the problems listed here below. They develop hypoglycemia because they're used to having high amounts of glucose in their blood, and they are making enough insulin to absorb all that. Okay, and then what happens is their blood sugar supply is cut off, but their insulin is still being produced. And so what happens is they develop hypoglycemia. Right? So that's why all babies born to diabetic mothers have to have their blood sugar followed for probably at least 24 hours afterwards, and any baby over 4,000 grams also needs to. These babies are also at risk for hypocalcemia, hyperbilirubinemia, and polycythemia. Because of the hypoglycemia, their surfactant gets used up and they're at risk for respiratory distress. On top of that, they have the birth trauma that we already mentioned, and because they've been exposed to high levels of blood sugar, they're also at risk for congenital birth defects. So you want to identify risk factors for the baby developing hypoglycemia. Signs and symptoms of hypoglycemia include tremors or jitteriness, not very good tone, poor feeding, high-pitched cry, increased respiratory rate, temperature instability. If the baby is large for gestational age and exhibits any of those symptoms, you would want to check the blood sugar. Even if they weren't large for gestational age and they exhibited those symptoms, you would want to check the blood sugar. And then you would follow the policy. And usually that involves treating for a blood sugar less than 40. Um, what, what, what we usually do at Hoag is we let the baby breastfeed, and then after they breastfeed, we recheck the blood sugar. But if the mother's unable to breastfeed, you can give formula. If the blood sugar is below 25, then we usually start an IV and give D10. But you want to look at your hospital policy and follow that. So, what is meconium aspiration exactly? What happens is at some point in utero, the baby has an hypoxic episode. This causes a relaxation of the anal sphincter, and then the baby basically has a poop in utero. And because the meconium is the type of stool that is, it's called a meconium staining or a mech staining. Then when the baby's born, the baby aspirates that into their lungs, and that obstructs the airways, which causes an atelectasis, or if it's only a partial obstruction, it causes an pneumothorax. All right. As the baby's trying to cope with this, they use up their surfactant, and then they end up with not only a chemical pneumonitis, but respiratory distress. So how do we treat this? It really depends on how severe the meconium is, whether it's very thick like pea soup or very thin like a strong tea. Um, so what we usually do is we usually start an amnio infusion. This is to dilute the meconium, so that if it is really thick, we could dilute it out, get to a very thin consistency, so that even if the baby does aspirate, it's not going to be the particles that causes all the um, damage to the lungs. So when the baby's born, we're basically going to look at the baby and treat the baby based on how it looks. So if the baby comes out and isn't breathing and it has an APGAR of 5, then we are going to intubate, we are going to suction and get as much out of the airways as possible, and continue to treat as if the patient did aspirate it. If the baby comes out and the baby looks good, even though there was meconium, and let's say the 1 minute APGAR is an 8, then we probably aren't going to do that vigorous deep suctioning and not going to intubate. All right. This is in contrast to how we used to handle this maybe 6 or 7 years ago.